So video 7, pharmacologic treatment of hair pulling and skin picking disorders, SSRIs, and acetylcysteine and riluzole. So medication treatment. So important to note that a treatment for one BFRB can be generalized to the other BFRBs. So if one study is done in a hair pulling disorder, you can pretty much take that study and apply it to someone with skin picking disorder or any other specified OCRD that's a BFRB as well. Now, there have been multiple trials of fluoxetine. It has not been found to be effective. Sertraline was studied, only found to have a mild effect prior to addition of CBT. Chlamypuramine has been studied. Chlamypuramine is superior to zipramine in treatment, but really only mildly more effective than placebo. So chlamypuramine was one SSRI-like medication. Chlamypuramine is a tricyclic, of course, that acts as an SSRI. It's the one SSRI that was found to be somewhat superior to placebo, but again, only mildly. Other studies, escitalopram was done as an open-label study, was found to be somewhat effective. So what's happened is with most of the SSRIs, they've not really been found to be very efficacious in single standalone trials. However, there have been meta-analysis done, and when you pool all the studies together, the results are much more positive. And it does seem that in meta-analysis that the SSRIs do separate out at that point. There have been some meta-analysis where chlamypuramine is shown to be better than placebo and maybe somewhat better than the SSRIs. Note that there have been some analysis that have shown that SSRIs do not work. There have been some analysis that show that they do work. At this time, my recommendation is that still we use SSRIs in these patients and that the SSRIs are first-line medications in accordance with usual OCD treatment protocol. Again, all the SSRIs are considered equivalent with BFRBs, and OCD dosing is always preferred in these cases. There have been some other studies that have been done with other medications. One of the biggest bombshells that has been N-acetylcysteine, otherwise known as NAC. NAC is an amino acid that's available over the counter. You can buy it in many health food stores. It causes glial cells to release glutamate into the extrasynaptic space. There, what it does, it stimulates inhibitory glutamate receptors, which reduces synaptic release of glutamate. So NAC was studied with 50 patients with hair pulling disorder at dosage ranging between 1,200 and 2,400 milligrams a day. It was noticed that 56% improved very much versus only 16% improving with placebo. And that's a pretty significant result. There was a repeat study that was done in 2013 with a very similar design. It was done in children ages 8 to 17. It should be noted that there was no improvement versus placebo in that cohort. I think the big takeaway home point with that is that children are not little adults, and just because a medication works in children or adults doesn't mean it's going to work in the opposite population. And especially meds that work in adults do not always work in children. So there was a second NAC study that was done in 66 adults with skin picking disorder. The dosage ranged between 1,200 and 3,000 milligrams a day, so a little higher on the top end, and 47% improved versus 19% on placebo. So the results were very, very similar to the first NAC study with adults. So therefore, I think that NAC is certainly a medication that is potentially useful in patients with BFRBs and maybe something that has been a bit of a game changer with this in the sense that it's certainly gotten a lot of popularity. I still do recommend that since there are no formal consensus guidelines on what's first-line treatment, NAC or SSRIs, I do recommend that patients still follow typical OCD protocol. The patient should be placed on SSRIs first. However, the difference with that being if the patient does not respond or only minimally responds to the SSRI, the first logical augmentation choice should be NAC at that point. NAC is usually started at 600 milligrams BID. You can increase to 1,200 BID if needed. Also, please note that the studies have all been short-term, so there's no long-term evidence with NAC as there is with SSRIs, and there isn't a lot of long-term experience with NAC except clinically, as there is with SSRIs. However, no side effects have been reported, and it is thought to be mostly safe. Again, because it's something that's over the counter and because there are multiple manufacturers, there's no guarantee that someone gets what they're buying over the counter, that they're getting what they're actually paying for. Again, is another reason why I always still recommend that SSRIs are first-line treatment for BFRBs and NAC being a secondary augmentation if needed. Other medications. Riluzole is a medication that has been approved for ALS, but is shown to have strong efficacy in OCD. It has been effective in case series. Now, naltrexone has been used in the past due to perceived similarity with substance abuse disorders. People thinking, well, naltrexone works for substance abuse disorders. BFRBs kind of acts like a substance use disorder. Naltrexone did not separate from placebo, is not recommended in these patients. Lamotrigine, at best, mixed results, not recommended. Topiramate has been studied. There's been a positive case series. However, significant side effects with this medication, again, makes this something that is not recommended at this time. Now, there is very little data for the use of antipsychotics, and most of it is mixed or open label trials or case series. And therefore, most of the antipsychotics, which are often commonly and typically used in BFRBs, are not recommended. There is one exception to that. There was one positive double-blind placebo-controlled trial with olanzapine used at 10 milligrams daily. As a result, with these BFRBs, if someone has failed SSRIs and if they have failed NAC, I will recommend that they use olanzapine as a second-line augmentation then at that time. Other medications, Joranbanol has been shown to be effective in one case series. Methylphenidate can be used to treat ADHD without increasing hair pulling disorder symptoms. There is always some concerns with people that using stimulants can make these symptoms worse. That may not be the case. There are case reports that anterior cingulotomy have been successful in the most severe of these patients. Usually, some surgical interventions, such as deep brain stimulation, is not recommended because, of course, that creates another wound. And so cingulotomies tend to be what is recommended. If I can review again, SSRIs tend to be the first line. NAC, I think, makes a good augmentation. Olanzapine is a good secondary augmentation. So the key points. As of this time, SSRIs as well as Chlamypuramine still should be considered first-line medication treatment for BFRBs. You still should use OCD doses in SSRI pharmacotherapy. So, for example, doses like 400 milligrams of sertraline a day. If you're not using 400 milligrams of sertraline, you're not using sertraline. NAC as a glutamatergic agent has been shown to work very well in 2 studies of adults only. So I think it can be used in adults as augmentation to the SSRIs. It can also be used as a standalone medication in patients who will not tolerate the SSRIs. Commonly, I see naltrexone, antipsychotics, and lamotrigine used in this population. They've been shown to have little or no benefit and are therefore not recommended despite their popularity among clinicians. Now, the one exception to that is olanzapine. At 10 milligrams, it was shown to be effective in one study. Therefore, it can be considered second-line augmentation behind NAC. Thank you.